So I'm Mark Balceniuk. I'm a surgical resident at the University of Rochester, and I'm presenting today on opioid use in vascular surgery following EVAR. Nationally, there's been a widespread epidemic of opioid overdose, and surprisingly, we've found that a lot of it is due to physician overprescription. And so we wanted to evaluate how we, as a division in Rochester, what our prescribing habits are, and see if there's something that we could do to help curtail the problem. So our study was a two-phase study. We evaluated both the inpatient and outpatient phase after an EVAR to see what the opioid use habits were of our patients. And what we found was surprising. We found that most patients didn't require any opioids at all. And on the inpatient side, those who did require opioids were then given an opioid prescription to go home with, not surprisingly. But what was surprising, those who took the prescription home hardly used any of the pills. We found that there was approximately 30 pills prescribed per patient, and only 5 pills per patient were actually used, so quite overprescription. Historically, I would say that most patients after a surgical procedure, vascular or otherwise, typically have received an opioid, just because the assumption is that if you have an operation, you're going to have pain afterwards, and we want to try to manage that pain for the patients. Typically, we would prescribe probably 5 milligrams of oxycodone 4 times a day or something like that, depending on what the patient requires. And most people would prescribe that for a week, maybe 2 weeks, until their first follow-up visit after the operation. Then we could reevaluate their pain then. The problem of opioids is more of a recent phenomenon, and so nowadays patients, yes, are more aware of the problem, and it's facilitated a better discussion between the patients and physicians pre and post-operatively. But historically, no, most patients actually wanted the pain medication with the concern that they might just have some pain at home and wanted to have something available for them. It's one of the things we're evaluating in our next set of studies is looking at the comparison between open procedures and percutaneous. What we found with the current studies is that patients are really not needing it either for open or percutaneous access, at least. Logically, it makes sense that a percutaneous procedure would require fewer pain medications, and we saw that there was a little bit, but not significantly different. In the vascular surgery division, we're currently undergoing creation of a formal program for opioid prescription following these procedures. But anecdotally, yes, most of our physicians have curtailed their opioid prescribing after a variety of procedures. We evaluated this in carotid revascularization as well, and have almost completely stopped prescribing after those procedures. So yes, we've definitely seen the improvement. I would say the first thing is to respond to the needs of the patient. Some patients may require pain medication because they're having significant pain, and that's not something to discount. But if patients are not reporting significant pain, I think it's on us as physicians and surgeons to reduce our prescriptions because we've shown that really patients don't need it and won't take it. So to just put out that prescription into the community is probably more harmful than beneficial.